Yes, we can start. Over to
Renu?
Ren.
Yes, ma'am. I'll start. Warm welcome to each one of you attending the third day of international webinar Global Trends in Mental Health, organized by Madras Christian College in collaboration with Commonwealth Organization for Social Work. Adam Hans said, and I quote, "Mental health needs a great deal of attention. It's the final taboo and it needs to be faced and dealt with." The first day, we listened to the speakers share their experience from the Caribbean and America. And yesterday, we listened to the mental health trends from Asia and Pacific. Today, our speakers are from Africa and Europe. We have two chairpersons for the day, Dr. David N. Jones and Dr. Godfrey Bohen. We will end this international webinar with a valedictory program. Before we move to the session, I would like to give few general instructions to the participants. For those in Zoom, please post your questions in the Q&A box and in YouTube, the chat box. It will be answered at the end of the session. A feedback link will be shared at the end of the session in both Zoom and YouTube. Kindly fill them to receive your certificates. Let us now proceed to the first session, which will be chaired by Dr. Godfrey Bohen. Dr. Godfrey Bohen is the Policy, Research and Practice Improvement Lead for the British Association of Social Workers, UK. Dr. Bohen is the author of 2 books on social work. He has also published on social work in Africa. He is currently writing a chapter in Encyclopedia of the UN Sustainable Development Goals, SDG, on the role of social work in meeting SDG on poverty. Dr. Bohen is a board member of the Journal Practice, Social Work in Action, and Community of Wealth Organization for Social Work. He is a person that can come up with interesting and creative ideas. Sir loves to work with children and has intensely worked with disabled children and in child protection. Over to you, sir.
Thank you very much, Renu. That's a wonderful introduction. I'm grateful for that. Hello, everyone. Good morning to you from London. Good afternoon to you wherever you are, and good evening to you also wherever you are. As has been said, my name is Dr. Godfrey Bowen, and I have great pleasure in chairing this session, the first session of the Trends on Trends in Mental Health. This session will consist of 3 speakers. The first person to speak will be Dr. Noah Modritso. Dr. Modritso is the president of the International Federation of Social Workers Africa region, and he's also a lecturer and an academic at Midland State University in Zimbabwe. He has long-standing research, practice, and teaching experience in mental health and social work practice in Zimbabwe and the Africa region. He will give us an overview of mental health from an African perspective, and he will talk about the need for us all as practitioners, researchers, and academics to think about African cultural perspective in our interactions with those who are experiencing mental distress. Dr. Modriso is unable to join us today, so we have a recorded video of his presentation, which will play after I've done the introduction. When the video of Dr. Modriso has finished playing, I'm pleased that we'll be joined by Mrs. Loveness Iman, who is the head of social work and also the Dean of Social Sciences at the Catholic University of Malawi. Mrs. Iman is a nurse and also a midwife and has long-standing experience of practice in psychiatric hospitals in Malawi. She would explain to us how COVID-19 has impacted on psychosocial needs in Africa. After her presentation, would be joined by Mr. Joy Kandiwere, who is the head of social work at the St. John of God Hospitalizer. He will speak more specifically about how social workers have engaged and addressed the needs of people experiencing mental distress from COVID within the Malawi context. Each of these presentations should last about 7 or 8 minutes, and then we will take questions from you, our audience. We encourage you to interact with us using the Q&A box and also the chat box at the bottom of your screen. So I will now pause for a minute and give the technical team the opportunity to start the video of Dr. Noor Modriso's presentation. Many thanks. Presentation.
Thank you very much, Godfred, for the opportunity. Thank you very much, viewers and followers of the conference, which we are discussing an important issue around mental health and connecting mental health with COVID-19 in the time that we are in. But it will be also important to appreciate and understand mental health from an African perspective. Mental health is linked to our human being, our being, and our connectedness as a people. For we are because others are. The aspect and concept of Ubuntu is central to our well-being as a people in Africa. We are individuals, but individuals connected to the connectedness and the group to which we exist. Therefore, our well-being, including our mental well-being, is closely related to our connectedness to the group. From an Afrocentric perspective and a traditional way of looking at mental health, in Zimbabwe, for instance, mental health is connected to our spiritual being, our ancestors, our tradition, our values. Therefore, it is linked to this connectedness that we are and we have to our present, our past, and our future. From an Afrocentric perspective and a Zimbabwean traditional view as well, our mental health and our being is also connected to our deeds, what we do and how we relate to others. In brackets, the sins that we'll have committed or the sins of our ancestors can also affect our being and our mental health. It is also connected into how we relate to others and what we do to others today, yesterday, and tomorrow. So we need to understand that mental health is linked to our being today, yesterday, and tomorrow. And also from an African perspective in Zimbabwe, things do not just happen. For instance, COVID-19 does not happen. It is related to the sins of the past. What we did, what we didn't do for our ancestors, or what we ought to do. I can leave you to read about this mental health and illness. For instance, you can read Bodilon, you can read Chavunduka, you can read other people in terms of traditional explanations of mental illness in Africa. Let me also talk about how mental health is related to issues around the socio-cultural environment in which we exist in Africa. Here, I would want to borrow and move away from the Afrocentric view that I've just given to look at the socio-cultural perspective of mental health, which links mental health to issues such as poverty, to issues such as our living conditions. COVID-19, we all agree, has exposed poverty, has exposed our living and deplorable living conditions in which we exist, more so in Africa. These living conditions and circumstances that we are in, looking at it from those lenses, does explain some of the issues surrounding our mental well-being in Africa. Therefore, issues to do with our relationships, even our connectedness, relationships within our living spaces, issues to do with violence, issues to do with poverty, issues to do with lack, cannot be disassociated with mental health. Therefore, one can be inclined to argue that mental health is linked to our being, our existence, our living conditions in Africa. Now, having talked about and linking mental health to our connectedness, our being as a people, COVID-19, we all agree, will and is affecting us and affecting our mental being. We all agree that the regimes that have been put forward to try and arrest and control COVID-19 will remove the connectedness and our being as an African people who are connected. And COVID-19 has disconnected us from the group, which also means that our mental health has been affected by distancing, by inability to be with family, which also affects our being and our ability to also do our rituals, to have our normal way of life. I do appreciate that the next speaker will zero in on some of the causes and COVID-19. But if we look at mental health and COVID-19, one can argue that there is a case for mental health where mental health itself is being affected and impacted not only by COVID-19, because it also induces death, but also the introduced regimes in trying to combat COVID-19 will remove us from the connectedness, which is dire and needed for our being and our mental health from an Afrocentric view. It also removes us from being able to fulfill the cultural and spiritual rituals that are associated with us being African, which might also affect our being, our past, our present, and our future. Because I have argued that our mental health from that perspective is linked to our present, our past, and our future. More so when you also look at the circumstances that we are living in. COVID-19 is linked to our livelihoods. Poverty and COVID-19, there is a relationship. Therefore, poverty will enhance stress, will enhance anxiety. Death itself will enhance anxiety as we are losing people in Africa due to COVID-19. People are also anxious. Will they have COVID-19? And I have also started by saying that in Africa and from an Afrocentric perspective, things do not just happen. Therefore, such issues about COVID-19 will also bring issues to do with spirituality and our understanding in terms of the cause and effect. Why COVID-19? Why am I losing my loved ones? All these issues will have an impact on our mental health. Now, having said this, we are arguing that COVID-19 is linked to our well-being and our mental health. The following speakers who will speak after me will now zero in on COVID-19 and how it has affected us practically, not from a general perspective. The last speaker, as you were saying, will also touch on issues to do with what we as social workers are doing in practical sense. But before that happens, I would also want to say, it is also then critical for us to look at COVID-19 from an Afrocentric perspective. This will also help us understand and work with people and communities, understanding them from where they are and their belief systems. This is also important for these regimes and interventions to work, because you want to appreciate people and their belief systems. It will also assist in interventions in understanding the role of traditional leaders in communities and traditional ways of thinking. Because if we are arrogant in not taking this on board, this is where now interventions fail. It is important to tailor-make interventions with people's belief systems and then coming up and working with people from where they are. And once again, thank you for this opportunity to present and talk about mental health in Africa, but relating it now and narrowing it to COVID-19. Thank you.
No. So Dr. Maurizio there in his presentation has spoken really powerfully about the interaction and place of traditional cultural beliefs in understanding of mental health. I now want to ask you, our audience, both on Zoom and also listening on YouTube, to share with us your own experiences about your cultural beliefs, your culture, your religion, and also traditional beliefs, how that translates into your understanding of mental health. And dare I say, you're even welcome to challenge the views of our presenters. I now want to hand over to the second speaker, Mrs. Loveness Imam, who will speak in greater detail about the psychosocial needs of people in Malawi, which have been impacted upon by COVID-19. So over to you, Loveness.
Thank you so much, Dr. Godfred. I also appreciate the first speaker, Dr. Noel, for his presentation, which has greatly put an introduction to my presentation. As he has said in his presentation, that COVID-19 is linked to our well-being and also to our mental health. It is very true that COVID-19 has brought a lot of stress, has brought panic and fear to the world, and let alone to Africa. A lot of people have been engulfed with fear, whether those performing a critical function during the COVID-19 pandemic, or those whose work is essential to the survival of people affected by COVID-19, or those people who try to keep systems and services functioning for the benefit of everyone. Everyone has been attacked by or affected by COVID-19 in their psychological being. Sometimes just by hearing the COVID-19 news has left others with fear of being infected, fear of contracting the disease, and fear of the aftermath of the disease. That what if I die? What if I'm sick and I die? What if my relatives will die? As the first speaker said, that it is also linked to our spirituality. So this has left a lot of work for social workers to look into the psychosocial needs of people. So social workers in Africa are working around the clock to support the emotional well-being of others during this challenging time. And one can make a difference to the well-being of people through how you interact and communicate during the COVID-19 response. Even if the interaction is only brief, it is also making a difference to people. Hence the need for psychosocial support for all people, as most people feel stressed during this pandemic. So social workers have got a very great role to play during this COVID-19. So they are also classified as essential workers because they are doing a job which cannot be done in hospitals. This presentation will dwell on the public health pyramid, which is used at a three-level way tier: the primary, the secondary, and the tertiary. The primary level, these are programs which target the entire population to provide and educate and support people before the problem occurs. So social workers are there to help interact and communicate with people in an empathetic manner. They are also there to help translate the COVID-19 information from reputable organizations like WHO and the other international social work bodies into local languages so that everyone, even people in the remotest areas, will be able to access the information. Remember, SDG 1 is not trying to not leave anyone behind. So even during this pandemic, we are not trying to leave everyone behind. So we start with translating the information to local languages. Social workers are also making sure that the information about the disease, about the treatments and services are also available to all people. And they are trying as much as possible to help people, to assist people to cope with emotions regarding the disease, helping in managing disruptions which happened when some countries went on lockdown because schools were disrupted, work was disrupted, and also families were disrupted. At secondary level, these are programs targeted to alleviate problems and prevent escalation of the problem. So social workers are available to create awareness on what process people should follow when they are not well. They are also supporting the vulnerable people, for example, the older persons, the children, and those with disabilities, those in prisons, and children who have gone against the law in order to understand and get information and valid information about COVID. They are also supporting those who are grieving by providing bereavement counseling and support alternatives to traditional mourning rituals. In Africa, our tradition, mostly if you're not a Muslim, when a relative dies, we don't mostly bury the same day. We have 2 to 3 days to 1 week to 2 weeks to mourn for the person before you finally bury them. But because of COVID-19, that has been disrupted. For example, in Malawi, when a person dies of COVID-19, a funeral ceremony is taking about 30 minutes from the hospital to the graveyard. And that has caused a lot of distress to the mourning rituals on how traditionally we do it. So social workers are available to provide bereaving counseling. They're also providing protection and support for families affected by domestic violence, affected by abuse, neglect, and exploitation. Remember, some countries went into lockdown, meaning that families were living together 24/7 in the same house, so chances of domestic violence were high. Also because of the psychosocial problems which COVID-19 has brought to the families. So social workers were there to provide support and protection to the families, and also to educate the people on early signs and symptoms of the disease so that they can seek proper treatment. And because of the pandemic, there have been a lot of misinformation, rumors, which is very common during any pandemic. So social workers are there to provide necessary and clear and accurate information to the communities by using concise language that will be easily understood. Be sure to use words that are age and developmental appropriate, depending on the group of people they are targeting to help at that particular time. To avoid using jargons and technical language because information is coming internationally, for example, from WHO. So they are trying to make sure that they simplify the message for everyone to understand. They're also trying to have written material in relevant languages, sometimes using visual aids. When needed, a translator is also present to help them convey the messages. At tertiary level, and at this level, it means somebody has been affected. They are there to provide treatment for those who are affected. So social workers are helping in managing disease-related symptoms using available medication. If one is not admitted, if somebody is admitted, it's then they are under the hands of the healthy care professionals. They also offer spiritual support where necessary, where someone is spiritually down, they also offer the support. social workers, they are also good listeners. So to be good listeners, they encourage the people for openness and sensitivity to feelings and emotional needs of the clients to make sure that they help them accordingly. They also notice the early signs of depression and anxiety. They also provide remote psychosocial support using available technology to contact at-risk families to help them cope by using a telephone, by using messages, and by using any form of technology they can use in order to help those families who are at risk, but they cannot physically help them. They also provide psychological first aid and counseling for persons diagnosed as COVID positive, and also to caregivers. Also, healthcare professionals are human beings who are also affected by the disease. So social workers are also helping their colleagues to cope with the pandemic. To sum it all, it is the duty of social workers to provide psychosocial support at all levels to everyone, whether infected or affected, including the caregivers. Because most of the times you find that the healthcare professionals are left behind because they are also busy working, and social workers are there to help. With the extended family system disturbed with COVID-19, psychosocial needs need to be taken seriously. Therefore, social workers are urged to be on top of the game in providing psychosocial support. And social workers continually are working in collaboration with other stakeholders like the Ministry or Department of Health in each and every country in order to have latest or current information at hand, which helps them to support their clients in the communities. Thank you so much.
Hi, Loveness.
Over to you, Dr. Godfred.
Yeah, thank you so much for that really helpful, detailed presentation, giving us really some specific and practical ways about how social workers are supporting people who are experiencing mental distress in Malawi. Thank you for that. I want to move on quickly to the third presenter, Joy, who I know has been able to join us. So Joy Kandewire is the head of social work in a psychiatric hospital in Malawi, and he will talk, giving us even more rounded picture about the sort of psychosocial support which is being provided by social workers. So I'd want to hand over to Joy now, to start his presentation. Joy, can you hear us? Okay. If Joy is unable to join us, we have a video of his presentation, which we will now prepare to show to you, our audience. But as we get ready for that, can I just ask you, Loveness, a question which our audience, a member of the audience has posed to us. And the question is that we haven't really said much detail about the role of poverty and mental distress in the Malawian context. And I just wondered whether you can share your thoughts with us on that question.
Thank you so much, Godfred. I left it purposely because I know Joy will tackle on that in detail. So the next presenter will ably tackle that problem in detail. So I'm not sure whether I should answer or we should answer at the end.
Share your thoughts with us from your perspective anyway. Okay,
thank you so much. Yes, poverty has been linked to our mental health lately because when you're poor, you don't have the basic needs, and then you are under lockdown. That's one reason why Malawi didn't go on lockdown, because there were those arguments that if people go on lockdown, those people who are poor, is the government going to give them something to help them maintain their day-to-day lives? So the government wasn't clear on that. And because of that, a human rights body plus other people went to court to get an injunction. So that injunction helped or stopped the lockdown in Malawi, because we were looking at all those factors that somebody is poor and then you leave them in the house, that will aggravate their mental problem, and then it will be a problem now even if they don't catch the COVID, but then you exacerbate the symptoms of mental health, which will be even difficult for them to open up because they are under lockdown.
Thank you very much. That's a really powerful example of the tensions between different social policies, trying to resolve issues around poverty, whilst also trying to ensure public health, and then also protect people's human rights. You get those intentions, that itself can affect how countries have managed the pandemic. Thank you very much for that. I'm sure we'll have an opportunity to discuss that in more detail later on. What I would also want to say to our audiences, we'd be interested in hearing your own experiences from your country perspective about how some of these tensions were managed by policymakers in the countries that you practice. I will now hopefully hand over to the technical team, who by now have the video ready to show us. Technical team, over to you.
This opportunity. As my colleagues have already presented, I'm now going to take you through how mental health social workers have addressed mental health issues in Malawi. So this will be a practical experience, and we're also going to highlight some of the common issues that mental health social workers do experience and how we are providing the service in Malawi. Now, for starters, I would like us to know that in Malawi, we have the Ministry of Health, and under the Ministry of Health, we have one mental health psychiatric hospital, which is based in Zomba. And for that one, we also have another inpatient unit, which is operational at one of the central hospitals in the country. Besides that, in Malawi, we also have St. John of God Hospital Services. That is where I also work, whereby we are a non-governmental hospital that is also specialized in providing mental health services. So we have two centers. One is in the northern region of the country, and the other one in the central. And further to that, we also have various institutions that offer mental health services, such as Mehuka, UNECO, and Makoha, as my PowerPoint slides are going to depict shortly. Now I want us to go straight to the impact of mental health, the impact that COVID-19 has on mental health. Now, some of the issues that we are currently facing as a country is that we have an increased amount of anxiety amongst service users and service providers alike, because everyone is terrified with the pandemic. Everyone is afraid. Everyone is having a cultural shock of what is happening. As Dr. Murizo had already touched on it, in most cases for African context, we usually like to link some of the current challenges to our cultural perspectives. That culturally, what is it that has happened for this to come about, and what is it that we need to do? So for that in itself, it is having a very huge impact on how people are handling the issue. They are having different perspectives and beliefs on the same. The second thing that the pandemic has had on Malawi, to be particular, is that we have closed some of the community-based programs. As a practicing profession, we usually had this approach of conducting community-based awareness campaigns and community-based services so that people should not be institutionalized for the mental health services. But at the moment, due to the pandemic, we have closed some of the community-based programs. And further to that, some of the institutions that are coming up with projects that are aiming at lessening the impact of COVID-19, they are underutilizing the aspect of mental health. As a result, we are having few individuals who are being assisted with mental health services or mental wellness as they are also being treated from the pandemic of COVID-19. And further to that, the other impact that we as social workers are also facing in the midst of the COVID pandemic is that some of the activities that we usually used to do are no longer being practiced, such as conducting home visits. Now we're encouraging either to use phones or maybe use other source of communications in order to make interventions or maybe to provide counseling and the like, which has a less way of enhancing the well-being of individuals, because once you have an interface dialogue, at least you are able to appreciate some of the challenges that one is facing and how best you can create interventions. While just using a media platform, it becomes so much challenging to be able to make a comprehensive assessment. So these are some of the impacts that COVID-19 is having on the mental health provision of services in Malawi. Now, next to this, I would like to present on the practical experience on how social workers are conducting services and what is it that we are doing. For starters, we are still embarking on capacity building, that is engaging service users in goal setting, decision making, planning, implementing some of the suggested solutions, and then evaluating how best somebody is coping out from their social challenges. Further to that, we're also conducting guardian sessions, which we aim at educating, empowering on the need of social support, and advocating for anti-discriminatory practice. Because in most cases, when one is having a mental health issue and also in the midst of this COVID pandemic, people tend to maybe pull back from being closer to them. So they distance themselves in terms of interaction and giving support and advice. So it is our role to see to it that people still maintain a good relationship in the midst of this pandemic. And further to that, we are also engaging in community awareness campaigns. As my colleague, Mrs. Iman, has just presented, we are trying our best to reach out to the communities with information on how best they can keep safe from COVID-19 and also promoting their mental wellness. They should not be preoccupied with the thoughts of being anxious about the pandemic and what will happen to them, but rather they should maintain a positive attitude towards their livelihoods and how best to live in their families. So in that instance, we are trying our best to see to it that issues of stigma and discrimination are being tackled. People are still receiving an empowerment on how best to uplift their socioeconomic functioning. Families should be able to support one another in the midst of this pandemic. And then there should be an inclusion of human rights in the midst of addressing each other. We are, in most cases, trying our best to inform people that somebody who is having COVID-19 should not be referred to as a COVID-19 case, but we should respect that they are still human beings and they deserve to be respected and receive their human dignity as required.
Hi, technical team.
Aisha, Ananya, what happened?
Thank you for that. We lost the connection, it would seem, but we have been getting some really helpful and insightful questions from the audience, and I want to take this opportunity to have a panel discussion with Loveness, if she's still here with us. Loveness, can you hear me? Yes, Loveness is still here with us. Loveness, one of the key issues that was mentioned in the presentation is really how social workers have used technology in the African context to overcome some of the challenges around resources and infrastructure in managing the needs of people who have experienced COVID and mental distress. I just wondered whether you could give us a bit more, some more practical insights into how this has occurred in Malawi.
Thank you so much, Dr. Godfred. In Malawi, people are using the social media more because even the updates on the figures of who are infected, how many people have died, is coming through social media. So social workers are also taking advantage of the same by using social media, putting their numbers where people can reach, and if possible, going to reach out to those people, but maintaining social distance. But mostly it's social media like WhatsApp, which has been greatly involved in this. And on spiritual support, I've seen a question somewhere on spiritual support. So before I go, let me answer it. What social workers are doing for spiritual support mostly is to link the patient or the guardians to their pastors or to their reverends or to their line church. So they are able to link them so that the pastors can take it up from there and help them. If they seem to share the same faith, then it's not a problem. Then a social worker just goes into the spiritual support of the patient or the guardian. Thank you.
Thank you so much. Thank you so much, Loveness. I also wanted to ask you a question about how the needs of older people or elders have been managed during the pandemic. And permit me to use a comparison of the UK and the African context. In the UK, there's a feeling that older people have been affected disproportionately by COVID. But arguably, this is because of the social positioning of older people and the discrimination that they face. I know that in the African context, older people are given a higher social status and they are respected for their wisdom. How has that really been related to the management of the needs of older people who have been affected by COVID, the traditional beliefs about elders?
Thank you so much, Dr. Godfred. I'll give you an example of Malawi because that's where I am based. So older people have been looked after greatly because we have got a good number of organizations who deal with older persons, and their umbrella body, the Malawi Network for Older Persons organizations, is on top of its game. What they've been doing is immediately when the pandemic was known that it has reached Africa, they started creating awareness to older persons in order to maintain social distancing, because they were told that because of their non-communicable diseases, which they have already, they are at risk of being infected. So they were told to stay at home as much as possible if they don't have anything important, unless they are going to the hospital for checkups or for medication filling, which they need to go on themselves, but otherwise they were encouraged to stay at home. And also organizations started at an earlier stage distributing masks and sanitizers and soap. In case they can't manage to use sanitizer, they were given soap, just a tablet of soap or tablets of soap, which was even easier for them to access, to be washing hands constantly, using a mask wherever they are going, because they are already old. So they've been looked after in a sense that they've been made to stay home more than anybody else. So they captured or they received the messages quite early during the time the pandemic reached Africa, or the numbers started getting high in Africa. And fortunately, we haven't lost many of them.
Great, thank you so much. And I want to ask you another question here from a member of the audience who is based in Nigeria. And their question, it relates to the point made earlier on that because of issues around poverty, there was some delay in enforcing lockdown in Malawi. The question from the audience member is, do you think that really has had any impact on the spread of the disease in Malawi? Do you think that has had any impact on transmission rates, or it hasn't had that much impact? Just interested in your thoughts on that question.
Very interesting indeed. Thank you. Yes, lockdown didn't even happen in Malawi. There were some partial lockdowns, which some groups of people were conducting. And also the government enforced minimizing gatherings, and also that if people go to church, we should follow all the necessary procedures. If you go to work, should follow all the precautionary procedures. But total lockdown didn't happen. And at the same time, we had the campaign period, because we were due to vote for another president in June. So it was now a dilemma whether people should be attending the campaign rallies or not. Unfortunately, people were interested to hear what these politicians will bring on the table. And we had a lot of people flocking to attend the campaign rallies. We voted in June, governments changed, and the numbers started going up. So up to today, we are trying to find out the relationship of no lockdown and increased the numbers. But the numbers took time to start rising. And I remember last week I was talking to a doctor who said, we are also contributing this to, because we are in winter now in Malawi. So the weather has been really, really cold comparing to how cold Africa can be. So he said, the numbers have gone up for various reasons. So we cannot totally contribute to no lockdown that the numbers went up. There might be other factors which also contributed. Thank you.
Thank you very much. And now I'm shifting the question, I'm shifting the discussion to the training of social workers, because I know that's your expertise. You are, after all, Dean of Social Sciences. How has the pandemic impacted on the training of social workers? For instance, in the curriculum that is delivered, and even how they access the training facilities?
Thank you so much. The pandemic has really affected our social work students because they cannot go for internship, for example, because now organizations or even government offices, because we mainly rely on the social service, under the Ministry of Gender, Social Affairs, Child and Disability, which helps to take a lot of students for internship. But then the government enforced the rule that people should be working in shifts so that they can minimize the numbers of people in the offices. Because of that, they cannot allow the students to go on internship. So as much as some universities has made slide on online teaching, but after the online teaching, the practical side is affected. So our students are home now, waiting for the situation to stabilize, then they can go on practice education. So that side, really, our students have been affected. But otherwise, theory part has been moving, has been going on, apart from some other universities where they couldn't manage to go on online learning. But those who managed to do online learning, they've managed to finish the theory part, but the practical part is affected countrywide. And that will cause a delay in finishing the curriculum because we have to wait, and then when the situation stabilizes, that's when we can send them on practice, and it means they will delay maybe for half a year or even a year to graduate. And that will also bring backlog on the academia, because a group will not graduate, the group which will not graduate this year who need to go on internship next year with the other group, which will be a problem. So we'll cross the bridge when we are there for how we'll manage the backlog of students.
Okay, Loveness, thank you so much. And this has been a really rich, helpful discussion. what I have taken from it is really how actually in relation to the pandemic, the world, it has had really different impacts across the globe. And the wealth of a country doesn't really, what's the word to use? It's been irrespective of the wealth of a particular nation, you know. But actually socioeconomic circumstances have also massively impacted on how policymakers have designed policies to combat the pandemic. I'm sure that there'll be lots and lots of this for our next session to pick up on. Our next session is the Europe session, and they would also be discussing these issues really from the European perspective. So I'd like to bring the African session to a close now. And I'd like to say a very big thank you to you, Loveness, for joining us, and also our other speakers who recorded their presentations for us. I'm also grateful to the audience for all their questions which they've been posing to us. We've not been able to answer all of them in this Africa session, but the Europe panelists will also be seeing the questions, and I hope that they'll be able to pick up some of them and address them in their discussions. So thank you so much for joining us again. I'll now hand over to Renu to introduce the Europe session.
Thank you, Dr. Gottfried, for chairing the session effectively. Thank you to all the speakers from Africa who share their experience about social work practices in Africa with special focus on Malawi. It was very informative. Now we move on to the second session, which will be chaired by Dr. David N. Jones. Dr. David N. Jones, the COSW representative of the Commonwealth Institution, was the president of the International Federation of Social Workers, IFSW, 2006 to 2010. He has worked hard as a global coordinator of the Global Agenda for Social Work and Social Development, and has taken interest in editing global overview reports. Sir has published and spoken extensively on social work practice, social service management, and children's services in UK and overseas. He has published material on child protection, management, and regulation of social work and disasters and international social policy. He is generous and a genuine person and is known for networking. I now invite Dr. David N. Jones to chair the session. Over to you, sir.
Hello, everybody. Thank you very much for this fascinating webinar series, and to our colleagues in Africa for all those perspectives. I was just thinking as I was listening of the impact of poverty before we move into the European context, which is perhaps a little different. But I know from my own experience in visiting India and in working in Africa, how the impact of poverty is so serious when there is a lockdown, as there has been, or the transport stops, as in India, or people are not able to go out in the evening, as in parts of Africa. For people who live on $1 or $2 a day, hustling on the street, just doing one job here for small money and another job for small money, if they are not able to go out, their life has immediately been in crisis. And this is something which we need to think more about. The impact in Europe is obviously different, but for the mental health of people who depend on earning a few rupees, a few shillings, a few dollars here or there, it is a real problem. So we may come back to that for discussion later on, but now this session is looking at the impact on mental health of COVID-19 in Europe. And we have two speakers who are joining us, one from Malta and one from the UK. And first of all, I'm going to Dr. Josiane Skerry, who is at the University of Malta, and I see on my screen has joined us, was listening to some of the Africa presentation as well. Josiane is the head of the Department of Mental Health in the Faculty of Health Sciences in the University of Malta, got her doctorate at the University of Nottingham, where I also qualified in social work, although at a different time. So we both have some links with the University of Nottingham. And Dr. Skerry is also very interested in the views of service users, in people who've got long-term health conditions. So there are lots of background experience. So Josiane, it's really nice to see you there in Malta. Welcome. And just for our colleagues, our two speakers are speaking for about 20 minutes each. I think that's what we agreed, Josiane. So around that amount of time, it's over to you, and welcome to this presentation.
Well, thank you, David. And I would also like to say a good day to all. I'm going to share my screen so that you can follow the presentation with me. David, is that fine? Can it be seen?
Yes, that is absolutely perfect.
Okay, thank you. Allow me please to thank the organizing committee for this excellent webinar, which I've been following over the last 3 days. I'd like to thank you for that. And before I begin my presentation, I would just like to thank my colleague, Dr. Alexei Sammut, who processed the data which I will be presenting today. Data which has been collected from a local organization where basically individuals could phone in requesting assistance. So a very quick preview, overview. What is my presentation going to consist of? Well, I'll be presenting details about the number of calls made to a mental health helpline, and what did these calls consist? What were they asking help for? What type of calls were they? And I'm going to be presenting data for 6 months. So basically divided into 2 phases as shown on my slide. Phase 1 consists of the calls being made between December 7th and March 6th. And I'm going to classify this as the pre-COVID phase. Why? Because between December 7th and March 6th in Malta, there were no persons who were yet diagnosed having COVID. But in phase 2, which began on March the 7th, and I've taken another 3-month period, so that I can compare, March 7th to June 6th represents the COVID phase. So this is the time when basically persons in Malta, and I'll give more detail about that, were being diagnosed with COVID. Now, I could present this as numbers to you or type of calls, but I feel that giving that information without embedding it in a context would be a huge disservice to the experiences of these individuals. As social workers, as professionals, we know that a person with a mental health condition is not a person living in a vacuum, but this person is a person who lives within a context. And if we do not understand and explore that context, I feel that we are losing out on very, very important information which, if we are aware of it, helps to improve the communication between the client and the professional. And if we really, and I'm sure we are, because I mean, even from the chats I've been following over these 3 days, since we are so concerned about person-centered care actually emphasizes the importance of understanding the beliefs of the client, but not only that, but that we as health professionals also reflect on our encounters, on our beliefs, and how even our beliefs may influence our behavior when relating to again, clients. And I'll end with 2 slides on how can we encourage our clients basically in their journey towards self-empowerment. I just want to show you this bar chart very quickly, but I'll come to it later on. If you look at the number of calls between December and May, April, the number of calls in April, you can see that that bar itself, you know, is extreme. It seems to stand out. Something happened in April in Malta, March, April. What was happening? Why did the number of calls increase so much in April? What was happening? And that's the journey that I'd like you to join in with me today when we move through what was happening in Malta month by month. But where do I come from? So maybe not everyone knows where Malta is. Malta is some tiny islands off the coast of Sicily, 191 kilometers away. We have a population of about 500,000 individuals with a population density of 1,600 persons per kilometer squared. December, January, we were hearing about a virus in China. I can't say that we were not responding to it. A second, I'll just stop that. Just a minute. So we were hearing about the virus in China, but we were seeing that something as something somewhat distant to us. We have heard of viruses in other countries, and these viruses have not always. And these viruses in other countries, for example, we can mention SARS, Ebola, these viruses never reached our shores. So the fact that China was perceived as a country where there was no contact, no flights, we were seeing that as something somewhat distant. But yes, we were hearing about it. But things changed in Malta towards the end of February, especially. In the end of February, we heard about the first case in Sicily. And here people began to pay more attention. Something was happening close to our country, Sicily. With Sicily, we have a lot of connections, whether by sea, by air, frequent flights. So persons began to take this, if you want to say, aspect more seriously. People began to give more attention now, again, onto the media. What is this virus? We don't know enough about it. How are other countries coping with it? We were doing this because I would say that we wanted to have more control over a situation where we felt we did not have much or any. The media from all over the world, whether it was Sky News, CNN, Italian, channels, Maltese, whatever, they were also bombarding us with information. And as you can see on the slide, clips such as that, where we saw trucks carrying bodies out of Bergamo, bodies where the local crematorium could not sort of deal with these numbers. So these persons were being carried out by the Italian army to another place, basically to deal with the number of deaths. We were being bombarded with people being interviewed, people struggling because they could not be with their loved ones when they were dying. It was such a personal moment, such a private moment. And we were hearing about their loved ones dying on their own, isolated, surrounded only by, at times, hospital staff. Misinformation was also rife at that time. If you look at the slide, on top, you've got a picture showing a supermarket and loads of people outside the door, queuing outside the door. And that image was being passed around through various media, amongst which WhatsApp. So can you imagine yourself sitting at home? You're receiving these messages, whether WhatsApp, whether Facebook, whatever, seeing people queuing up. What would come to your mind? I ask you in a way, the audience, what would come to your mind? You'd probably think, so these people are queuing, they're going to take everything, and I'll be left with nothing. We're entering a crisis. I need to stock up. And in Malta, as what happened in a number of other countries, people began this panic buying. Basic items, oil, flour, milk, toilet paper, everything, people were just taking as much as they could and stocking. And this panic was quite rife throughout the country. But before I go on to the COVID phase, I would like to give a summary or a resume to our group, to the audience. So from December to March, a 3-month period, there were 241 persons who reached out to the helpline, reached out to this, maybe I should say, organization asking for help. We know that the highest percentage were mainly females, so 67% were females. Now, we also know that from the contact made, approximately half of the calls were requests for help for the person themselves. So the person is contacting the organization and the help requested was for themselves. But we also noticed that approximately also half the calls or contact were people asking help for family members or friends. So we're seeing that the number of contacts can be equally divided between asking help for themselves and asking help for family and friends. And these are some examples of typical calls during the pre-COVID time. So in the first case, we have a mother phoning up about her son who's aggressive, lacking hygiene, not, sleep patterns affected, threatening people. She doesn't know if it's due to alcohol, drugs, or a mental health problem, and her son is resistant to help. There were quite a lot of calls about emotional issues, so people going through a separation, people struggling with a partner, with a spouse, with a child, and also calls regarding information about different diseases or about services offered both by the organization itself or, for example, there was one person who had a family relative with Parkinson's, and she was asking the organization, can you refer me to services that I can make use of, avail of? But things changed. March 7th, we found our first local case of COVID in Malta. Now, throughout March, cases were being diagnosed, but I would say that the numbers did not go above 20 within a day. I would say also that we reacted quite quickly. So for example, we closed down our schools, we closed down university, the hospital, there were massive changes, making spaces in areas to put in more beds, more ventilators, purchasing of equipment. Now, religious services were also terminated, and throughout the presentations, I've seen points on the chat of how did you respond to such spiritual challenges? Well, many religious activities began to be transmitted through television, which is very, very commonly used, especially even by our elderly. So they were provided with various religious activities. But in Malta, people are also, even our elderly, have also moved quite a lot onto Facebook. So Facebook was even being used for spreading of information on religious activities, spiritual activities. My department also, both through the help of staff and students, we opened up a page on Facebook, which within a few days, we had over 1,000 people enrolled, following our page, in which we used to put up information in 2 languages, both Maltese and English. Maltese to ensure that we would obviously be able to reach out to certain persons maybe who did not have the opportunity, maybe the older generation, of going to school. So they had maybe a very poor command of English, so we could reach out to them. English was, again, a medium that can be used both for Maltese individuals, but also the many persons, international persons, foreigners who live in Malta. So we felt that we had to reach out to everyone. Our elderly and vulnerable were placed on a partial lockdown. So they were, though there were some mixed messages at times, they were instructed to, if possible, remain at home unless there's an essential service and there isn't somebody who can help. To also, though, give you a full picture, pharmacies also began delivering medicines, etc., to such persons, for example, the elderly, etc., who ideally were meant to stay at home. In the meantime, we were bombarded with media, by the media about COVID, about the importance of social distancing, and I could say almost all the speakers before me spoke about culture. And this was an issue in Maltese culture because we are very tactile. We are persons who like to, you know, sort of hug each other, etc. So this was quite a challenge for us. But April, that graph in the beginning, why April? Why the spike? 7 to 8, the numbers suddenly rose before the 20 that we were used to. And within those first few days, we had the first 3 deaths. That sent shockwaves through the population. And in fact, you can notice that the spike in April can be associated with, here you have another graph showing you the number of cases. So the spike in April seemed to be associated both with the number of cases as well as with the number of deaths. What were they calling about? We noticed, you can see for the month of April, I'll be very quick here, we noticed an increase in the number of calls showing anxiety, distress, worry, depression, loneliness, people having problems with medication management where they had doubts on how much medication should they be taking, can they change their medication. Other people were phoning up about problems of abuse. I'm now with a person who's abusing me for more time. How can I live with this person? So here I put down a number of aspects which people were bringing up. So the problem of, they were mentioning, some said I had a pre-existing condition, things have worsened. I'm terrified of contact with going on a bus, shopping. I'm afraid for myself and my family. People mentioning the fact that they couldn't support their relative. There was a time when visits were not allowed in hospitals, so I couldn't be with my loved one. My loved one is alone. Or I'm in quarantine, I need to support a relative. For example, my brother with schizophrenia. I can't approach this person. I'm afraid there will be a relapse. Obsessions, people, for example, one phoned up, obsessed that his car was full of this virus. Financial issues, as my colleagues before mentioned. Feelings of vulnerability, professionals, and this I noticed in the chats. How many professionals were putting down points of how can I cope with seeing my clients needing help and I can't reach out to them. I'd like to say also that in Malta, we have invested quite a lot of money and resources in community services where we have outreach teams who used to, even when there was the partial lockdown, keep constant telephone contact with vulnerable individuals. Okay, children terrified of contamination, physical problems, as indicated on the slide. Predictions of deaths in the media was also affecting people a lot. The anxiety when you're waiting for a swab. Currently, there is a relatively short waiting list of people who want to be swabbed, and then you have to wait a number of days also to get the results. So this is all a question of anxiety. So I'll end with this because I know I have only a minute left. How can we encourage our clients in self-empowerment? I've listed some very, very good links very, very quickly, which you can refer to and which have some very, very good even apps, etc., which can be used. The third link provides also an audio and exercises, say, for example, such as grounding, okay, which can also be used even with your clients on the phone. Don't forget yourselves, please. You are also important. So this link over here, where there's written the Schwartz Center, this provides interesting information for you as a professional and how to take care of your well-being. In another chat, somebody spoke about the issue of stigma. I've also uploaded a document for you, though, which speaks about targeting stigma. For example, using social influencers in your community who can help in this campaign. David, I have just a minute and I'll have to stop because it's time, okay? Finally, I would just like to state, if you saw the reasons why people were phoning up on the helpline, there were a number of cognitive distortions, catastrophizing thinking, the fortune teller type of thinking, overgeneralizing. So here we need to, again, work on the cognitive distortions which persons may be facing, and also showing them what is the evidence for something and what is the evidence sort of against something. And finally, so that I can finish, look at also helping them set goals. And here I have the acronym SMART. These goals must be specific, measurable, attainable, and time-bound. Thank you for your attention. I'll stop here. Thank you, David.
Josiane, thank you. That was a phenomenal overview of the real emotional impact on whole populations, even when the numbers are comparatively small, but we know this is having a big impact. And it is astonishing in a way how similar this is all around the world. Obviously, our culture, our environment change is varied, but we have such similar experiences of preparing and coping with the pandemic, and it throws up so many issues for our personal psychology, but also for our group living and for human rights and how governments relate to people. So there are so many challenges. But that was a really helpful overview, and thank you for the links at the end to the resources to help people, which really makes a difference. I hope that Frank is now with us as well, and we'll come back and have some questions after Frank has spoken. I'm just hoping that Frank is there. Yes, I see Frank is there. So I'm really pleased to welcome Professor Frank Keating, who's Professor in Social Work at the Department of Social Work in Royal Holloway College, which is part of the University of London. Very big, well-known, well-recognized, highly respected social work department based in London. And Frank has got a particular interest in working with Black and minority ethnic communities, particularly with young men. And we know that the pandemic is affecting minority communities. Actually, sometimes they're majority communities in some countries, but are affecting people's communities in different ways. So Frank, I'm looking forward to your reflections on being based in London and working with these different communities, and perhaps particularly with young men who are feeling particularly cross, I think, about the pandemic restrictions. Like many of us are, we're feeling irritated. Why are we being controlled in this way? And that is breaking out into all sorts of tensions. So Frank, over to you, and thank you for joining us.
Thank you, David. And first of all, thank you very much for the kind invitation to speak. I was asked to speak about COVID and mental health in England in generally, but as David said, my work focuses mainly on issues of race and mental health. And so what I thought I'll try and do in this presentation is to talk to you a little bit about, to use ethnicity and race as a case example of how COVID has affected certain groups in society, because COVID is not affecting everyone in the same way. And we have to acknowledge that. And I also wanted to highlight highlight how COVID has actually also highlighted the inequalities, particularly in the UK society, but I think the inequalities globally, and so I wanted to point to that. I'm going to try and share my screen and hope that works.
That's going well, Frank. Thank you.
From the beginning. Has that worked?
Yes, that's good. Thank you.
Great. Okay. And also to say, Josiana, was very impressed with all your graphics. I tried to put graphics in my presentation and PowerPoint crashed on me all the time. So I'm just sticking with text at the moment. So I'm going to do four things. I'm going to, first of all, take you through the context for Black and minority ethnic communities in general, and also specifically in mental health. Then I will look at COVID and Black and minority ethnic communities. I will then look at COVID and mental health and Black and minority ethnic communities. And finally, hopefully look at what are the implications for social work. So what is the context for Black and minority ethnic people in the UK? So also just to put this in context, Black and minority ethnic communities forms about 13% of the population. But when you look at all the at their history in the UK, then there's a long-standing history of disadvantage for Black and minority ethnic people in the UK. They, for example, fare worse on all indicators of health and social well-being. So, for example, they report poorer health, they live in poorer housing conditions, they are more likely to be unemployed or be on short-term contracts, and all those sort of things that put people at risk for poor health and poor well-being. And these disparities or these disadvantage in general is also reflected in mental health. And so the inequalities are replicated in mental health. And so, for example, people from Black and minority ethnic communities are more likely to be compulsorily hospitalized. They are more likely to be restrained while they're on hospital. They are less likely to be offered talking therapies. And they have poorer outcomes in mental health. And so there are serious inequalities for this group. And so you have to understand what I will next talk about in this context of serious disparities, serious inequalities, and serious evidence of disadvantage. And then you also have to locate this in the whole notion of what is called racial weathering. And racial weathering is an idea that says that the disadvantage that people experience in society is cumulative, and it predisposes people to poorer health. And so again, and this is what we see in Black and minority ethnic communities. So now I'll move on to COVID and BME people. And so COVID, again, remember I said that BME people or Black and minority ethnic people only make up 13% of the UK population. But when the data became available in the initial stages, there was evidence to show that 34% of all COVID admissions to hospital. And now we're only talking about admissions. We are not talking about the incidence in the community, because that's more difficult to collect, at least in the UK. We only collect data around that's based on hospital admissions. And so 30% of COVID admissions were from Black and minority ethnic communities. So quite significant when you think they're only 13% of the population. But also they were then four times more likely than other groups to die of a COVID infection. And going back to the 34% of COVID admissions, we know that there are other factors, risk factors for COVID. So, but when those risk factors were all taken into account, such as age, gender, so men are more likely to get it, then ethnicity and race is still a significant risk factor for COVID. So there's something happening here. And of course, I would argue, and all the evidence that we have is showing that in the UK, the pandemic has exacerbated the existing inequalities. And we know that people are more likely to lose their jobs, people are more likely to lose their homes. There is now pressures on our health services, on social care services, and this all compounds the issues for certain groups. And people have tried over the last few months to find explanations for this. And I think there is no simple explanation for why Black and minority ethnic people are affected. I would suggest that that there are complex structural issues, so sociological and social issues that underpins this issue. But there are also biological issues, because a lot of Black and minority ethnic people also already had pre-existing conditions and poorer health conditions. And this, of course, therefore put them at risk. But there are also behavioral issues. So I think Dr. Josiane was talking about how families behave differently. So we have loads of families that live intergenerationally. So it's more difficult to socially isolate. It's more difficult. And then the health messages that were given for these groups weren't particularly helpful or were not culturally specific. And so this, of course, had an impact. So that's COVID and BME people in general.
I wanted to say you were brilliant.
So, as my title said, invisibilizing race. So even though we had these significant figures showing up in the data, people have not acknowledged that race was an issue. Ethnicity was an issue here.
That made it a real challenge, didn't it?
Sorry, somebody's got their mic not muted, so I can hear background.
Sorry, yes, this is David Jones. Technical team, Godfred is not muted. Can you mute his microphone? Thank you, Godfred. Sorry, Frank.
That's okay. Thank you. So yes, invisibilizing race. As I said, when the statistics came available, people denied that it had anything to do with race and just said that this was a virus and that this virus does not discriminate. But when we looked at the first figures, so here's something, the first 10 medical doctors who died from COVID were from Black and minority ethnic groups. And this was, when I first saw this, I raised it with colleagues and we looked at all the papers, we looked at all the news reports, and there was no mention of their ethnicity. What people were focusing on is that these were medical doctors, and if our medics start dying, what's going on here? And people started panicking, and then we had all these messages that we have to protect our National Health Service. But people have not focused on the fact that the first 10 medical doctors who died from COVID were from Black and minority ethnic backgrounds. Then when you look at health and social care workers, they were the first 100 health and social care workers from who died from COVID were from minority ethnic communities. So again, quite a stark statistic. It wasn't picked up, and it's only when these were raised by certain groups, because we also had Black Lives Matter, and then people started taking note of some of these issues, but it took a while for people to take note of this. Our government had a review done by an organization called Public Health England. And in June, this review brought out their report, and they acknowledged that there are issues around ethnicity, but then there were no recommendations for action. There were no policy recommendations. And the whole issue was then just further invisibilized and further seen as not really important. I must say that has now changed, because there were quite a lot of pressure from those of groups in our communities. So now I'll just briefly look at COVID and mental health. Now, again, people in these presentations, and I'm terribly sorry I haven't been able to follow all the presentations. I have followed some, but of course, we've all been talking about the mental health impacts of COVID. So just want to take you through. So the key thing here is that people with pre-existing conditions are at heightened risk. And so, as I've already said, that if people from Black and minority ethnic communities already have higher rates of mental health issues, then you are more likely to also see that this is going to affect them disproportionately. But 69% of adults are feeling worried about the effects of COVID. And so now there's a greater, in fact, some people are saying that we're going to also have a mental health crisis in the UK because the focus is so much on dealing with the virus itself, and that healthcare workers are not actually trained to deal with the mental health effects of COVID. So again, a serious issue here. And unfortunately, there is still limited primary data on the impact of COVID on mental health for BME groups. I looked at all the statistics, and the statistics will be talking about the numbers of people who admitted to hospital, the numbers of people who died, some breakdown of those numbers, but there is very limited data on how the COVID has impacted mental health for BME groups. And of course, as Dr. David already said, that there are some issues for young people from Black and minority communities, and they seem to be so significantly affected, not by COVID, because we know that younger people seem to be less likely to get the serious version of the virus, but it still has a significant impact on their mental health. And so one study in the UK found the following, that there was and they compared the figures during COVID this year and the same period last year, and they found that there was a 30% increase in self-harm concerns. There was a 27% increase in suicidal thoughts, and there was 9% increase in depression. Now, you know, we normally expect to see depression in adulthood, not depression in young people. So again, significant mental health issues for BME young people, and this raises challenges for how we'd want to be working with them. So I'm just going to give you a brief case example before I finish. So this is a young woman by the name of Samara Linton, and she wrote a piece in a women's mental health magazine, Women's Health magazine, and I was asked to do a commentary on this. So it's a young Black woman. She's a medic, and she was working on the front line, and she also had underlying mental health issues. And the impact of working on the front line had such a damaging effect on her mental health that she actually had to stop working. And so, you know, so if you think that if somebody, a trained medic on the front line, found this too stressful to be part of it, then you wonder how other people who are less experienced, less trained, what the issues for them might be. And this is what Dr. Linton says. And she says, and she made a clear link between racism and her mental health. And she says, systemic racism has always affected my mental health, but now I find it overwhelming. And that's the point when she decided to stop working and just stay at home. So really sad case of how COVID has affected someone's mental health, but also a woman and a person from a Black and minority ethnic background. So the question I would want to ask here is, Is COVID racist? Quite difficult to say, quite tricky to say. But I would certainly argue, along with other people who've raised this as well, in saying that COVID reminds us of the inequalities in our society. And this is not only in the UK, but I think it also reminds of the inequalities globally. And then I think a second point I want to raise here, it further deepens inequality in our world, and I think we need some strategies to address the deep-seated inequalities in our society. So I will end by just looking at some implications for social work. So I think as social workers, as mental health social workers, we need to acknowledge the cumulative effects of racism on mental health. That's the first step. I would also say we need to accept that the COVID disparities are a result of structural inequality. It has nothing to do with people's ethnicity. That's important, but we need to look at the structural inequalities, and of course that would have to consider ethnicity as a risk factor here. And then finally, I think we should make mental health equality a priority. So it's not just about mental health should be a priority, but mental health equality should be a priority. Thank you very much.
Thank you, Frank and Josiane, for two really insightful perspectives on the impact of COVID on two quite different European cultures and environments. Malta, a very small island in the middle of the Mediterranean Sea, but used to connecting with countries all around. So in that sense, quite open, a seafaring country with lots of connections. And the UK with its multi-ethnic community, particularly in London and the big cities. But we're finding similar issues all around, that where there are poorer communities, where people do not have access to good health services, whatever your background, that has an impact, and that is what we know. And perhaps this pandemic is teaching us what in the 19th century, in the early stages of industrialization, people realized that the health of cities affects everybody in the end, regardless of your wealth. We've seen in Africa where servants move from the slum areas to work in houses of richer people, that can lead to the virus spreading. And so for all of us, our health actually, it seems to me, depends on the health of the whole community, which is why it is so important that health for all is a message which the WHO, the World Health Organization, has been spreading, and why the Sustainable Development Goals are so important. In the end, we are not islands, all of us. We cannot protect ourselves from community. We all interrelate with each other, however big or grand or wealthy we are, or however poor. And we need to show respect for each other. And if we do not do that, then we have some of these crises. We have some questions that I've been picking up, Frank and Josiane, and I'm just trying to think where would be the best place to start. But perhaps there was a big question about the impact of on the social sector, on our own services. What's that going to do? We know, for example, not only in Europe, but in Africa as well, we've heard people are talking about using social media for much more connection with service users, with people who want to seek help. But also there are the pressures, as Frank was telling us, on staff themselves and their fear of bringing the virus to their own families. This is not going to be something that's going to go away quickly. Do we have any first reflections on what this is doing to our own services? Josiane, I'll come to you first, and then Frank, and then we'll go look at some of the service user issues. I think we've got about 10, 15 minutes for questions. So Josiane?
Okay. Well, first of all, David, the impact on social workers, the impact on social workers is very heavy. In fact, I have a feeling, I mean, again, from even some research that we've been conducting, that social workers and other people on the front line are carrying a very, very heavy burden on themselves. And the issue is that, in a way, we should consider that to provide person-centered care, we need to think about even this impact on ourselves, you know, the psychological impact on ourselves. As you mentioned, I mean, in Malta, we've had persons who, when COVID first sort of was diagnosed, they moved out of their home for a period of time because of this huge fear of infecting their relatives. So we had families where, again, the children and again, a parent or a grandparent, whoever was providing support, weren't seeing, you know, the social worker, the professional for months. What happened lately, though, in Malta was we did a month where the situation improved. However, from what happened a week ago there was a huge party in a hotel attended by many young persons. There was a person who was carrying the virus, and that has spread. So all again, we were in June feeling that we had, and we were mentioned as a country who had coped well with COVID. All of a sudden again, those professionals who had, you know, for months on end, you know, sort of even sacrificed their own well-being, etc., now are finding themselves again, most possibly having to recommence, you know, those measures that they had done previously. So is it again a question of people leaving, moving out of the family residence because of this huge fear, as you're saying, of infecting others? But there's another thing. I'm noticing that not only was there that increase in calls that I mentioned, that means that social workers are also facing more demands on them to provide support. So if we had looked at the month of, I mean, April, May, where we had 1,500 calls for help, social workers, and again, I don't feel that I feel that they have so much on their plate that it's becoming a huge challenge and a burden on their mental health and even physical health, you know, in order to cope. So I think this is something that maybe something I can mention, David, is also that in person-centered care, they mentioned the importance of reflective practice. And they speak about what we call Schwartz rounds. And Schwartz rounds would mean, for example, that social workers can, for example, through an online medium, reflect and discuss with colleagues, with other individuals. And that will even prevent social workers who often forget themselves and their well-being from feeling so isolated by reflecting with other people. And I think that would help as well when it comes to the burden they experience.
And Patricia from Malta has just put in the chat box that the association in Malta provided webinars or contacts for people. And I know in the British Association, we've also had helplines, and the different associations have been very active providing contact. Frank, do you have any perspectives on the impact on staff of these challenges?
I think in the UK, there was such a focus on the National Health Service, but the people were saying the reasons why Black and minority ethnic people were affected so disproportionately is that they were working in the front line. And so even though they may have had issues in their families, they still went out to work. And that made them more at risk to you know, to be infected with the virus, and therefore they were disproportionately affected. But there's also issues where they say that Black people are less likely to resist management or a senior person. If they ask them to work, they will say, I'll come to work, I'll do my job, even though they might be ill. And so that's when I say structurally people are putting themselves at risk, and they had not been given the protection. And then in social care services, it was even worse, because we know that health care workers in nursing homes were not given protective PPE, or the personal protective equipment, and we know that again spreads the virus and the infection. So it's how we protect staff at the front line is important.
And this is, it seems to me, a real challenge to the management of social services and indeed of health services. I think there is some evidence that in some places, well, management has been very inconsistent in thinking about the personal support of staff. Particularly if you work in government bureaucracies, there's a sort of mindset of you've just got to get on and deal with it, and you've got to make sure the performance indicators are delivered. And perhaps in the health service, there's a little more awareness of the personal impact and managing the support of staff.
Yeah.
And that is actually a job of management. And now I think with this COVID crisis, management has got to recognize that you cannot just keep pressure on people, you have to work with people's own experience.
Yes.
I move on to another question, perhaps. There's been a number of questions about abuse of people. There's abuse of older people, domestic abuse. We know that all around the world there has been an increase in ill treatment of people in families, and that this has been a challenge. You've already referred to this in your presentations. Do you have any further reflections on services or ways of helping people who are feeling abused in this lockdown situation? I think we're all having to think of new ways of engaging with this. Frank, would you have any thoughts?
I mean, I meant to say in my presentation also that a lot of the support that Black and minority ethnic communities experience are being offered in what we call the Black voluntary sector. I mean, in the international context, you probably would call it the non-governmental sector. And I think the Black voluntary sector has been doing quite a lot of work, and I work with small groups in the community, and their workloads have increased. And they have provided support that is culturally competent, culturally appropriate, culturally relevant, but also racially sensitive. And I think that's what we need. We need services that speak to people's needs. And that's how we can tackle some of the inequalities.
David, I think it's very important that we continue to strengthen care within from the community, within the community setting. And at times it's even a question of this outreaching to members of our members, even the elderly, etc., in the community, as well as supporting these individuals, these persons. So I really see the importance as well of strengthening a community services. Not just small. I mean, I think it's a global issue as well.
One of the intriguing things in some countries has been, in some cultures, has been the increase in informal support within communities. When people have been locked down, and people become more aware of their neighbours who aren't able to get out and shopping, or have got to shield, as it's been called in some countries. Shielding is when you keep yourself away from risk of infection. And there's been a lot of social capital, if you like, has been built up in all communities when people have been at home and have been able to offer that. And is that something that is sustainable? Are there ways of encouraging that to continue? And perhaps that is going to be really important, because all governments are under huge financial pressures. And with Frank talked about the voluntary sector, but we know that in European countries, the amount of money that's going into the voluntary sector is being reduced, and some voluntary organizations are having to lay off staff, make them redundant, because they haven't got resources to continue paying them. How about community resilience, Josiane?
David, locally, as you said, the community has, I've seen this I mean, I think there was someone who wrote in the chat, sort of, is everything all negative from this COVID experience? But I think I would also mention that there have been even some positive aspects. For example, we've got a number of organizations locally who are, for example, delivering, for example, food items to persons who are in need. And they have quite a good setup of collecting the items and even, for example, transporting them to different individuals. So lately also, I was asking a number of persons who have in fact, due to their chronic illness, ended up mainly, I would say, locked in their homes. And it was interesting how, for example, even a number of them, even though they were living in that situation, came up with even some positive aspects, which as, for example, one of them mentioned, he told me, would you believe it? I had 40 years, I mean, believe it or not, of photographs lying in a cupboard. And it's the first time in my life I found the time to look at them, you know, sort of place them in order, and all the lovely memories that came back with that. So, you know, it's interesting how, as you're saying, COVID has had a huge challenge on us. But I'm also seeing this aspect, as you mentioned, even of community arising to the situation. As I mentioned, pharmacies actually delivering medicines, you know, to people at home. Neighbors, for example, as you mentioned, doing the shopping for others. So, you know, there are, even with all the challenges COVID has given us, I'm seeing sort of initiatives in the community which I maybe weren't so apparent.
And the challenge is, can we keep this going? Is there a new normal which will enable that community resilience to continue? Yes. I don't know. I feel pessimistic, but I would hope that we could do something. Frank, I just wanted the last question. I don't know if you have any thoughts about this. One of the groups of people who have been particularly hard hit have been parents of children with autism or disabilities, and people who are caring for people with dementia. I know personally from experience of talking with people in that situation, the ways of getting help, of getting some respite have disappeared. They've basically been locked down with this challenge for 4 months or more. Do you have any reflections on that, just quickly?
I suppose you know, the pandemic has raised so many issues, and I think I had been drawn into looking at ways of supporting more mental health issues. So I have not really done much work around parenting. I've written on parenting and mental health, but not so much around this. But I can see some of the difficulties here. But I think what we will need is also, we need to make sure that all health and social care professionals have the mental health knowledge. And I think this is what's lacking, that people do not have I've seen some social work programs in the UK where they do an hour's lecture on mental health through a 3-year course. And I find that shocking. So I think it's also where we put, because mental health is integral to our health. And I think what we should do is we should equip our health and social care workers with the knowledge to respond to mental health issues.
Yeah, I feel very, very, very strongly that the first basic training for social work has got to give you a grounding in all these different areas, health and mental health, law. You cannot become an expert. There are some people who, in my view, stupidly think you can become a specialist on a 2-year course. You need to have a start, a grounding in all of these areas: childcare, older people. Families are families, and you need to understand all those different elements before you move on to specialize. Josiane, did you have any final thoughts on people coping with long-term conditions and children with disabilities, autism, and so on? Just 1 minute, I'm afraid.
1 minute, okay. No, David, I'd like to say something which I think is also important, to try to maintain even a routine. And this is important not only for us as professionals, but even there was one of the questions on the chat about children having autism. Okay, this importance of even maintaining a routine. So even if it's just a question of waking up, having a coffee, getting out of your pajama, putting on, changing into clothes, but that we try to maintain a routine. Maybe it's true in a scenario which isn't, which is in a way the new normal. Regarding also, I'll just end with this, the question about autism. There, you can also find a very, very interesting site on the internet. It's called the Autism Focused Intervention and Resources Modules. And this deals with supporting children with, for example, autism during the COVID challenge that we're living at present. So maintaining a routine, yes, sort of, but even this site I've mentioned gives some very practical ways of how people can help, with when they have children with a disability or with autism.
Thank you
I think
so
I
much.
my minute, did I?
Yes.
I don't have time.
I think both of you, thank you so much for keeping to time in your presentations and for bringing everything together. And I think that's been a really positive final session for our webinar. So to Josiane Skerry from Malta and Frank Keating from London, UK, thank you both very much. And we are now moving into the valediction series, and I hope that Sylvia Daisy is there ready to give us some overview. Or I see Renu, are you going to connect us back into the valediction series? But thank you very much.
Thank you, Dr. David. Thank you for successfully chairing the final session. Thank you to Dr. Josiane for sharing about the impact of COVID-19 on Malta, and Professor Keating for a session on racism and COVID-19. It was an insightful session. Thank you all for attending the 3-day international webinar and making it successful. I'm sure that most of us were able to learn and gain new perspectives from different continents. John F. Kennedy said, and I quote, "As we express our gratitude, we must never forget that the highest appreciation is not to utter words, but to live by them." We thank God Almighty for making this webinar a great success and in bringing us all together from different continents and have successfully reached the valedictory program. A summary report will be presented by Dr. A. Sylvia Daisy, Board Member, COSW India. Over to you, ma'am.
Can you see my screen?
Yes.
Can you see my screen?
Sylvia, we saw a blue screen. I don't know if you want to try sharing again.
You need to share your screen. We are not seeing your screen. Please share your screen. Yeah. Now it's coming. Go to the full presentation mode. Yes.
Yes, sir.
Yeah. Clear. Go ahead.
Good evening, one and all. Summary report on international webinar on global trends in mental health, organized by Madras Christian College in collaboration with Commonwealth Organization for Social Work. The international webinar on global trends in mental health has been a great example for collaboration during pandemic situation. The discussion on the webinar was initiated by Dr. David N. Jones, Commonwealth Organization for Social Work, representative to Commonwealth institutions in the month of May 2020. Mr. Theo, the chair, COSW, gave full freedom to work in this endeavor. Dr. Gottfried Bohen took this webinar to a greater level by giving suggestions that the speakers should be from all around the world and the sessions need to be continent-wise. Dr. A. Sylvia Daisy, board member, COSW, suggested to collaborate with Madras Christian College, and Dr. Miriam, head of the Department of Social Work, aided stream, Madras Christian College, gracefully accepted the proposal. Dr. Prince Annadurai, Associate Professor of Department of Social Work, being the webinar organizer with a team of students, involved himself wholeheartedly in this endeavor. And today we are in this valedictory function of 3 days international webinar. Statistics relevant to the webinar. The webinar was planned and implemented for 3 days, each day, 2 hours, altogether 6 hours to get 360-degree view on mental health in 360 minutes. We could find that a significant number of social work students, practitioners, researchers, and academicians have participated in this webinar. There were close to 2,500 attendees, and there were around 10K views of the online webinar. There were 23 speakers from 5 different continents. Out of 23 speakers, there were 20 mental health professionals and close to 1,000 chats were answered during the webinar. And all these chats were healthy chats relevant to mental health. The interesting and significant learning in this 360 minutes webinar is as follows. There is a need to address mental health issues all around the world in this pandemic. Human rights-based approach plays a vital role in social work field. It is important to apply a whole of society approach to protect and promote mental health. The usage of artificial intelligence by the social workers is need of the hour. The adoption of human-centered design to make social work intervention more effective. It is essential for social workers to have close network with health systems and local emergency departments. In all our work, we need to promote human dignity and spirituality for mental well-being. And removal of structural inequality is important. Thank you.
Thank you, ma'am. Concluding remarks will be given by Dr. David N. Jones, COSW representative, UK. Over to you, sir.
Thank you very much, Renu. And it feels, as always with these events, amazing that we have come so quickly to the concluding session. But my brief comments are to thank the people who have been involved. Sylvia mentioned them, and I think I would make special mention of Sylvia herself and the team at Madras Christian University and the students who've done such fantastic job with the technology. It has worked so smoothly. We prepared for the problems of connectivity. We had backup recordings and we were able to introduce them when we needed them. But we've also make sure that this webinar series has been mainly live, and that has given it a vibrancy and an immediacy which is really important, and it's connected our Commonwealth countries. This is historic. It's the first time there has been a Commonwealth social work webinar series across the whole of the Commonwealth with all regions, as Sylvia said in her statistics. And clearly we would be interested to think about how we do that further. So there's thanks to all the speakers, My thanks to my colleague Godfred in London, who's taken on a huge burden of the organisation, just recently joining the board of COSWA, Commonwealth Organisation for Social Work, and I know has been very involved working in the Commonwealth Secretariat and with the Independent Forum of Commonwealth Organisations. I know many of you will be saying, well, how can we get in contact with the Commonwealth Organisation for Social Work? And I have to say honestly that this is a very small organisation. It is entirely run voluntarily, but it has connections in all Commonwealth countries. And as a result of this webinar, we will be thinking again about how we broaden the base of our membership. At the moment, there is no charge to become a member. But we don't have the capacity to respond to several thousand applications quickly. So if you wish to be connected with the Commonwealth Organisation for Social Work, I think our president, our chair, Teo Ai Hua from Malaysia has been in this webinar series, has spoken. We will be working on how to get information to you about how you can join and become part of this Commonwealth family. Because as I said at the beginning, COSWA, the Commonwealth Organisation for Social Work, makes sure that the voice of social workers, the experience of practitioners, feeds into the Commonwealth thinking through the other Commonwealth organisations that we're connected with and through the Commonwealth Secretariat and the heads of government meeting. So thanks to everybody who's been involved. My thanks to Prince, Annadurai, and all the colleagues, Dr. Miriam, Samuel, and of course, Dr. Wilson, who is the head of Madras Christian College, for making this possible. But perhaps I'll finish with this. As we were saying in this today, the COVID has exposed the realities of our social world. It has shown that there is great inequality. It has shown that that inequality makes life very difficult for people. But it has also shown that we are all connected around the world. It is pointless to try to build walls. It is pointless to try to cut ourselves off. In the end, we are connected, whether we're in the Commonwealth or whether we're talking about the International Federation of Social Workers or others. And social workers understand that, and our skill is in making connections, is in working with people to build relationships so that we can live together in peace and in harmony and respecting all. And in a way, that is what we have got to make sure the world learns out of this COVID pandemic, that we are connected, that we cannot break those connections. And so we must all work harder at building relationships and building those relationships for a positive future for the whole world. And I feel encouraged by that, even though I think the pandemic is going to leave us with many challenges for the years ahead. It will not go away quickly. So we need to keep talking, we need to keep building our relationships. And with that, thank you from the UK, thank you from the Commonwealth Organisation for Social Workers, and back to the team in Madras or Chennai, who are connecting us together. And thank you to our presenters who've presented us with such good skill and grace and have made this feel a very friendly environment. Renu, thank you to you and your colleagues, and back to you from the UK.
Thank you. Thank you.
Thank you, sir. Thank you, sir. Now, Dr. Miriam Samuel, Head, Department of Social Work, Madras Christian College.
Thank you, Renu. Dear colleagues from the Commonwealth Organization for Social Work and Madras Christian College, chairpersons who are there for the various sessions, speakers, and my dear participants. I'm very happy to meet you all again at the end of this three-day webinar on global trends in mental health, and really encouraged by the outcomes of this webinar, not just in terms of the number of speakers and participants we had, but largely the depth of knowledge that was shared, commitment of all those who work in the field of mental health, the dedication and enthusiasm of all the participants, and above all, the spiritual grace that has been bestowed on us on these 3 days. I think right through these 3 days, when we were talking of mental health, one of the things that came out very strongly was the focus on spirituality in mental health. And that is something that we've experienced, especially all of us who've been working together. It has been a very fruitful journey for all of us over the last 3 days. I'm also very touched by the commitment of all those who were involved. The organizers at COSW and at MCC, chairpersons, and all the speakers. I really felt listening to all these speakers, they were just not talks or PPTs that were presented, but rather they shared their deep experiences, their commitments. They were social workers who have walked their talk with us over these last 3 days. As we conclude, it is important for us to look at the way forward, hoping that this is just not an end, but the beginning of various initiatives for all of us wherever we are. To all the participants, it is hoped that you as social workers who are needed the most today will be able to put into practice the learnings from this webinar. Individuals, groups, and communities need us today as we grapple to find meaning to this pandemic that is affecting all our lives world over today. Let's commit to promote wellness, positivity, and resilience so we all can come out stronger out of the situation. This global platform has provided us opportunities to work together. I cannot imagine sitting in a small little town in the corner of India, bringing so many resource persons physically to conduct an international conference like this. But we were able to do this over the last 3 days, sitting in our little corners, being able to share, support, learn, and more than anything else, to say that we are all in this together and that there is a lot of bonding together and oneness together as we are trying to grapple with the situation. So I do hope that this webinar is the beginning of our relationships with many people who have participated. And for us at Madras Christian College, we really hope it is the beginning of a relationship with Commonwealth, Organization for Social Workers, and other social work organizations we have collaborated with in this webinar. At the Department of Social Work at Madras Christian College, we have strived to build our professional master's social work program on par with global standards. A number of our students have got their master's degree accredited by international bodies, whether it is in the UK, USA, Canada, Australia, or other places. So we do look forward to further collaboration with COSW, Dr. David, and Dr. Godfrey. We do hope that this relationship continues. Some of the areas I was thinking is looking at further programs in terms of exchange, student exchange, knowledge exchange, and sharing of resources. Future webinars, if we think of other pertinent areas like we've done over the last 3 days, and collaborative research projects. We have people from different continents here. I was really impressed by the kind of work that is taking place. And I'm sure a lot of us can come together to do a collaborative research across continents and come out with a wealth of evidence-based knowledge and practice that can be shared with a larger social work fraternity across the globe. This webinar is an important step forward to translate our knowledge into concrete actions. This COVID, as Professor Frank beautifully said, this COVID has reminded us of the inequalities that are there and how a pandemic or any disaster affects people very, very differently, especially marginalized communities and poorer communities. We need to pursue this effort and develop strategies at the ground level to promote mental health. It is my hope and prayer that each of us are encouraged through this webinar to live our own lives in wellness and promote well-being for all we work with. Let me thank you all once again for your active participation, especially my colleagues from COSW and Madras Christian College. A special word of appreciation to Dr. David, Dr. Godfrey, Dr. Sylvia, and Dr. Prince Annadurai. I look forward to many more years of collaboration and being able to share our knowledge across the globe and to further our collaboration. Thank you all very much. Stay safe and God bless.
Thank you, ma'am. Now I invite Dr. D. Prince Annadurai, organizer and associate professor, Madras Christian College, to propose the vote of thanks.
Hello, everyone. Good evening from India. I'm sure that I'm the most wanted speaker today because I'm going to close down this webinar with the word of thanks. It's going to come to an end. Thank you very much for being with us for all the 3 days. Our world is not going to be the same after COVID-19. So mental health trends will have paradigm shifts. So these are my own words and understanding I would like to share here. The trends keep changing, they are dynamic. So our understanding of the mental health issues, our interventions, even our knowledge, even the curriculum that we teach definitely will undergo a lot of changes. We never know which lives we influence or when or why, as said by Stephen King. Through this webinar, even if one person across this globe who participated or who is going to view our videos, YouTube, if they are impacted, I would say that that's the success of this webinar. To begin with, I would like to acknowledge Lord Jesus Christ, who is the center of Madras Christian College. This college was started by Scottish missionaries, 183-year-old institution, one of the oldest institutions in our country, for his grace which sustained us to successfully complete this conference. Bear with me being spiritual because that is also one of the important coping during this COVID-19. That is an important trend that we need to learn. So I would like to thank our distinguished guest, Dr. David Jones, COSW representative, Commonwealth Institutions UK, Dr. Godfrey Bohan, Policy Research and Practice Improvement Lead, British Association Social Workers UK. Now he had many friends and fans for him, the way in which he chaired the session. We got very good feedback from the participants. Thank you, Godfrey, for being the backbone of this particular webinar in all your possible ways. We'd like to acknowledge and thank Dr. P. Wilson, our Principal and Secretary of Madras Christian College, for his patronage and support. Mr. Sri Ganesh, the Vice President, Asia Pacific Region, IFSW India, for great support to this webinar from the beginning. From the Caribbean and Americas, Dr. Dentney Rock, Acting Head of the Institution for Gender and Development Studies, the University of West Indies. Mrs. Sharon Rose Gittens, President, Barbados Association of Social Workers, Barbados. Dr. Ermine Bellet, Consultant Psychiatrist, Barbados, for your insightful presentation. From Asia, one of the of mental health profession in India, Dr. R. Srinivasamurthy, Professor of Psychiatry from National Institute of Mental Health and Neurosciences. Dr. B. Sai Kumar, counselor and psychotherapist. He was also the previous head of the Department of Social Work from DG Vaishnava College, Chennai. Dr. K.S. Ramesh, Assistant Professor and Coordinator, Banyan Academy of Leadership in Mental Health from India. Mr. Theo, the Chairperson for Commonwealth Organization for Social Work from Malaysia. We thank you all. Gratitude. From Asia Pacific region, Ms. Naomi Spencer, and also for chairing the session. The Vice President, New South Wales Australian Association of Social Workers, Australia, Mrs. Pamela Trotman, for sharing her own personal experience that was really touching. Accredited mental health social worker, life member of Australian Association of Social Workers. We thank you, ma'am. Dr. Mr. Armando Riglio, the Community Partnership and Safety Coordinator, Wollongong City Council from Australia, focusing on the community perspectives in the COVID-19 situation. That was very useful, mainly for the people, those who are working in the communities. From Africa, Dr. Noel, the President of International Federation of Social Workers, Mr. Joy from Malawi, and Mrs. Launas Iman, the Dean of Faculty of Social Sciences, Catholic University of Malawi. One particular thing she mentioned, how we need to be accurate in giving information. That was also one of the important learning personally for me. Thank you so much for joining with us from Africa. From Europe, Joshian, Senior Lecturer, University of Malta. A lot of take-home message from your presentation. Professor Frank Keating, Professor in Social Work from University of London. A lot of practical examples, what you have told, it was really meaningful and appealing to all of us. And then the program organizers, my own head of the department, Dr. Miriam Samuel, she's also the president of Center for International Social Work in India, for her wholehearted support in the smooth conduct of this webinar. A special word of mention about my colleague, Dr. Sylvia Dicey. She's a board member, Commonwealth Organization for Social Work India. She is also a professor in Social Work Department in the evening stream of Madras Christian College. And I'm sure tonight she's going to have a good sleep. The past 2 weeks, I know how she worked day in and day night. And thank you very much. It was such a pleasure to work with you. My friend, Dr. Godfred Bohan, for your spirit and enthusiasm, the way you spearheaded whatever that you have taken up for this webinar. It was fantastic. My friend, Dr. David Jones, for your encouragement and leadership acumen and all your support from UK. A special word of thanks to my student organizers. They are the backbone of this conference. We have divided into different committees. The program committee was managed by Rishi Nathan and Ms. Shiba. Then documentation committee by Beulah and Reno. Mobilizing committee by Mr. Joseph and Stanley. Technical committee, Tasmin, Asher, Ruth, and Anania. These guys, they are working from different parts of the city and also from other cities. And they have coordinated among themselves. For example, Joseph, he was in a confinement area due to this COVID-19, the hotspot in Chennai. The corporation has sealed his place. He can't even come out of his house and take a walk on the streets. But somehow these guys managed, and we're really happy to work with this young and dynamic team. Thank you so much, my dear students. It was such a pleasure. I'm sure that it's because of you, everything went on well, and the same appreciation and acknowledgement from other speakers from other parts of the world. Once again, our sincere thanks, and we are really happy to work with you. God bless. So, with this, I would like to conclude. Thank you so much for being with us in this wonderful webinar. And I'm so excited, and I'm hoping that one day we are going to meet again in any part of the world in a different context. With that, we are going to conclude. Be safe, stay safe. May God be with you all. And greetings from Department of Social Work, Madras Christian College. Thank you once again.
Thank you, sir. Thank you all participants for your active participation throughout the 3 days. Without you all, the program wouldn't have been a success. Once again, I would like to thank all the speakers despite the different time zones who were able to contribute. The feedback link is shared in the chat box, both on Zoom as well as YouTube. Kindly fill them to receive your certificates. The certificates will be given within a week's time. Looking forward for your participation in our future programs. For more updates, please follow our Telegram group. Thank you all. Stay safe, stay home. Have a good evening.
Thank you all very much. Thank you so much for all your support.
Thank you so much. Thank you, everybody.
Thank you, dear.
Thank you. Take care, all of you.
Congratulations. Congratulations.
Well done.
Thank you. Well done. Bye.
Thank you to everybody.
Dr. Josiane.
Thank you.
Thank you.
Thank you, Professor Frank.
Thank you.
What is it then?
Thank you.